It's Nursing Care Plans Specialized Edition. And the students have asked me for this for a good while now, but I've always been hesitant because I didn't see where it was necessary. I honestly don't think it is still necessary. Right now, I'm sitting here, I have a prepared presentation for you of about 78 slides. I mean, some of them are title slides, but I still don't see where this is necessary. But students tend to think that it is necessary. So to be honest with you, I'm going to be making a point with this presentation, which is if you understand the nursing process, you can apply it to any situation.
One look and I breathe.
Peds or it's in a specialized area, that would require different interventions versus where it's in a generalized setting. Okay, you're not wrong, but there's something I needed you to get to, and Misha said it. Assessment, that is it. That is the only thing that is going to be different. If you know how to assess in the pediatric setting, then the nursing process continues the same as you learn it for any other setting. If you know how to assess gerontological situations, it's the same thing. If you conduct mental health assessments, then the rest of the nursing process is the same thing. The only thing that is different is the assessment. So as we go throughout the webinar today, I want to focus on the areas in terms of assessment that's different for each of these specialized areas. How does assessment differ? Because that's really the only thing you really need to get. I have some warnings for you. The first one that's not here is 1, this is not the basic or the fundamentals care plan course, right? It is not even the basic or the fundamental care plan webinar where we would have gone through the nursing process, explain how to conduct assessment, etc. This is a nursing care plan webinar specialized edition, so we're not going to be going into so much detail when we do the broad care plan webinar. That's 1. 2, all our webinars are loaded with information. So be prepared for that. Get something to drink, get a snack, something, because you're going to be bombarded with information. All our webinars and every single VHS cycle is going to demand your full attention, because if you get up and go to the bathroom, you're going to be very important. So be prepared to give us your full attention. The recordings are not promised. If they're saved, I will share them till my discretion. So those are the warnings for today. Any questions before we go ahead? Oh, I also like to ask for clarity, to ask you if you have clarity. So be prepared for me asking you if you're clear, and then expecting you to respond in the chat, clear or unclear. So these are the objectives for today. I expect that at the end of the session, you should be able to define and explain the role of nursing care plans in patient-centered care. You should be able to recognize unique care needs for patients in pediatric, geriatric, and mental health settings. You should be able to discuss the influence of developmental stages, aging, and mental health disorders on nursing interventions. You should be able to apply critical thinking to analyze real-life scenarios and implement tailored care plans. And you should be able to address barriers to effective care planning, such as patient non-compliance and resource constraints. We might not spend a lot of time on number 5. Let's see how quickly we can go through this webinar. So, a nursing care plan is a systematic evidence-based approach to individualized patient care. And to me, this means more than just going through those words. Nursing care plans must be prepared specifically for the patient you're preparing them for. We get into this habit of trying to regurgitate related factors, regurgitate goals, regurgitate interventions, and try to associate interventions with specific diagnostic labels. And then get lost in the process. And then if we do implement it, we get good patient outcomes because they weren't specific for the patient that we were preparing them for. We really don't prepare care plans for patients. We prepare care plans for our teachers for them to mark them. And we really need to get away from that. Even as students, you want to identify the value of nursing care plans. And in the TikTok world and the IG world, where every other post is like, I'm a nurse now and I'm not using care plans. Such a waste of my time. And I would see even some of you comment and say, yeah, like, I don't know what's the point. And sometimes I do respond and I'm like, the point is for you to be able to function as you are functioning now. And if you're not functioning well now, probably because you didn't write care plans in school. But I found in life, people don't know, like when you lack something, you don't always know that you lack it. If you are caring for a patient and all you can do is administer medication, you're not actively in conversations to lead to better outcomes for your patient, you're not initiating any treatment that could help the patient, you're just going through like the daily, you wake up, you come to work, you do the basics and you go home, then of course care plans would have seemed worthless to you, like a waste of time, because you didn't develop an appreciation of how much it could have helped and how much it could have helped with your development and your critical thinking. So if you don't know, then you just don't know, you know? But those who know and those who use it as a tool to develop their ability to think critically, those are the nurses who tend to function differently. Those are the nurses who tend to do more than just the basics when they're in patient care situations. And it doesn't mean that they're writing care plans as nurses. It means that
temporarily closed due to weather conditions. Oh, what?
because they were doing it, they developed what they needed to develop, and now they can function without having to write a physical care plan. So starting off with pediatrics, special consideration for pediatrics in terms of assessment, vital signs. So in the pediatric world, understanding and being able to recall the vital signs ranges or different age groups is something that takes a while to grasp, even for persons who are working in the field. I mean, I did pediatric nursing from 2015 to I think the beginning of COVID. And even while in that setting, care for patients who are infants, neonates to adolescents, it was still a challenge trying to recall what the normal ranges were. Over time, it becomes easier, especially if you're working with particular age groups for an extended time. But it still takes some getting used to when you're moved from one area to go work in another area with children of a different age group, because the vital signs differ. For example, the heart rate of a newborn is anywhere from 120 to 160, and the heart rate for a toddler is anywhere from 90 to 130. You know, and it differs. School age children, I think the scenario we're gonna have a 7-year-old, their heart rate is anywhere from 75 to 100. So you have to know the vital sign ranges for the different age groups to be able to conduct a proper assessment and then act on the data that you acquire when you're doing that assessment. You do, if the respiratory rate is elevated, you even know when it's elevated. What do you do when the heart rate is elevated? What is an elevated heart rate for this age group? So that's one of the first things you need to know. The vital signs ranges for the different age. Growth and development, you must be able to measure and determine if your patient is growing and developing normally for their age. Are they at the correct weight? Are they the correct length if they're infants? Do they have the expected height range? Are they meeting expected developmental milestones? Things like that. And if it's an infant, what's their head circumference? What are the fontanelles like? Right. Knowing the importance of palpating the fontanelles and checking if they're bulging or sunken, and knowing that one finding can indicate dehydration and another finding can indicate that the patient has fluid overload. So those are some key aspects of assessment in the pediatric setting. Pain assessment is also important in the pediatric setting, and the use of different pain scales for different age groups. If you have an infant who can't speak or even understand the display of emotion, then you know you'd have to use the FLAC scale for that. And if you're using the FLAC scale to assess the infant's pain, you know that it's an objective scale. So the data from that scale would go in objective assessment and not in your subjective assessment, because the FLAC scale assesses the facial response of the infant, the movement of their legs, overall activity, their cry, and their ability to be consoled. How quickly can they be consoled? All of that would be based on your observation of the nurse. So your FLAC score would go in your objective assessment. So that's how it differs in terms of assessment for peds versus the general population. If it's a child who is at the stage where they can understand what happiness looks like, what sadness looks like, then you can use the FACES pain scale for those children. And if it's an older child who now understands how to associate pain with a number and recognize meaning of numbers in terms of signifying intensity of pain, then we can use the numeric pain scale for those children. But pain assessment is an important part of psychosocial and emotional assessment is also very important. You have to take this into consideration when you are conducting pediatric assessment. So you're looking at the child's mood, their general behavior. The behavior, does it match their affect? How do they interact with other children? How do they interact with their parents? What's the parent-child dynamic? And it's not always indicative of abuse. Sometimes we see something that's not what we expect, in that they don't have a very good relationship. What's the parent and parent relationship? That's also part of psychosocial and emotional assessment in the pediatric setting, which is not an assessment that we typically do in the adult care setting. We don't assess parents in the adult setting, but we definitely have to do that in the pediatric setting. So look for any signs of anxiety, any signs of physical or emotional abuse, depression, and so forth. Assessing the family's knowledge of what's happening with the child, assessing the child's knowledge if they are school aged and above is also important. Nutrition and hydration, immunization, and health history are key points in pediatric assessment. So you must know what nutrition should be like for children of different age groups. You must know immunization schedules. What immunizations should children be receiving at what age group? How frequently do they need boosters? Things like that. So that's assessment knowledge that you must have when you're caring for patients in the pediatric setting. And something that you need to remember, if there is something that you need to assess, it means that there's the potential of you finding something abnormal. And the abnormal things are what we typically diagnose. So the abnormal things the risk for those abnormal things happening are what we typically diagnose. So if you're doing an assessment and you're checking to see if the child has been immunized, and when you check it, you realize that they have not been properly immunized, then that child is at risk for infection or some other diagnosis. So it's not just about remembering what to assess. Remembering what to assess also helps you to come up with your diagnoses as the nurse. Right? If you don't remember that you need to assess immunization, then you might forget to assess it, and then you miss an important diagnosis for know the key considerations so that you can remember to assess for them so that you don't miss important nursing diagnoses that need to be made. For neonates and infants, you must also check their reflexes. For toddlers and preschoolers, check for any signs of separation anxiety, and you have to make like an extra effort to gain their trust. For school-age children, they tend to be a little bit more cooperative than the younger children, but they still experience anxiety. So don't think that because they're more talkative, etc., they're not experiencing anxiety, and disregard their anxiety. Are you still hearing me? I see a message that my internet connection is unstable.
I'm
You hearing me?
We're hearing you.
Okay. Adolescents, they tend to be a little bit more cagey, but then it comes down to personality. If they're introverted, then they're going to speak less. If they're more extroverted, they tend to develop rapport with you a little bit quicker. But they require respect, privacy, and definitely a deeper connection with you to share more with you. So that's something for you to take into consideration. General principles to remember when caring for patients in the pediatric setting: you must involve the family as caregivers. So if the child leaves the hospital and the persons who are caring for them don't know how to care for them, they're going to end up back in the hospital shortly after. You have to involve the parents as part of their care. So when you're assessing a child, you will end up, in most cases, writing care plans that have to do with the family as well, and not just specific to the child. And this is how peds differ from adult care plans. And it's just about the assessment. So the assessment will lead to you having to diagnose the family and not just the patient. Don't forget to address developmental milestones and ensure that you are using age-appropriate care and non-threatening language and non-verbal behavior. Some common concerns in the pediatric setting: pain, immunization, nutrition. Common pediatric conditions: asthma, dehydration, and febrile seizures. Just keep those in mind. And we're going to go into our first scenario. So we have a patient. His name is John, 7-year-old boy. He has a history. He was diagnosed with asthma at age 4 with worsening symptoms during seasonal changes. His current symptoms are wheezing, shortness of breath, increased respiratory rate, use of accessory muscles, and oxygen saturation is 90% on room air. Trigger: recent exposure to pollen and dust. Parents' concern: parents express difficulty managing symptoms at home despite following prescribed albuterol inhaler regimen. They also express conflict over differing approaches to managing his condition. Mother expressed: his father and I argue about how to treat his condition. He wants to try alternative treatments suggested by his mother, and I don't want to do that. What diagnoses come to mind? Yes, Elisa. Hi, Elisa, by the way, a long time I don't see you. Elisa says, so true, I made a mistake today and told that toddler I'm taking her BP. The poor baby said, no, I don't want you to choke me. And send up her BP, oh gosh. Ineffective health maintenance Ineffective health maintenance. Okay. That's what we're getting. Ineffective breathing pattern. Ineffective breathing pattern. Caregiver role strain. Non-compliant is not a nursing diagnosis. Impaired gases exchange. Why am I not seeing the most important nursing diagnoses? All right, so let's look at the subjective data and objective data. Maybe that can help us. So subjective data, parents reported observing, and by the way, remember you can get subjective data from the patient or family members that are close to the patient. So in the pediatric setting, depending on the age of your patient, you're going to be collecting a lot of subjective data from the caregivers, not necessarily patient. Depends on the patient's age. So parents report observing wheezing, and we need to assess further. We can't just write wheezing auscultated. What just happened? Wheezing auscultated over lung fields. If we want to be excellent nurses, we have to note more than just wheezing. So what's the intensity of the wheezing? Is it harsh? Is it soft? Because we want to measure if the patient is improving, and the wheezing might not just go away in 30 minutes, but we can know that it's improving if it's less harsh, if the intensity has changed. So we also need to document the intensity of the wheezing. All right. Shortness of breath. We need to assess further. Whenever a patient complains of shortness of breath, we need to assess further. Is it on exertion? Is it at rest? What happens? What makes it worse? What makes it better? We always need to assess further. Difficulty breathing despite use of prescribed inhaler. We need to assess further. What could we possibly assess further as it relates to difficulty breathing despite use of prescribed inhaler? Anybody? You see me looking over here, the chat is over here on my other screen.
It's being used properly.
Exactly. So we don't just document that they've been using the inhaler. If the patient has asthma exacerbation and they have been using the inhaler, we have to check that they've been using it properly. All right. Parents report recent exposure to pollen and dust and history of asthma diagnosed at age 4 with symptoms worsening during seasonal changes. Parents report difficulty managing is asthma symptoms at home despite following the prescribed albuterol inhaler regime. Assess further. The mother expressed that she and the father argued because she's against using alternative treatment suggested by the father's side of the family. Always assess further. Why are we assessing further? Because we've realized that that's a potential problem. Even if we haven't concluded to ourselves yet that that's a problem, just put yourself in the situation. You're on the ward, 2 parents are there, there's obvious tension, they're not even standing close to each other. And when you go to assess and you start a conversation with them, the mother tells you that he wants to try alternative medicine and I don't know nothing about that. His mother won't try it and I'm against it and we argue about it all the time. You have a patient here that's admitted due to asthma exacerbation. It could be that that child was home with the dad and they didn't use the albuterol because he's not for the albuterol. You don't know. But something is happening between the parents that could potentially be causing this child's situation to worsen. So it has to be something that you assess further. You have to find some time to get these parents in a private setting and talk to them about what's going on, because that child is now at risk. We can't draw any conclusions, but that conflict between the parents could be jeopardizing that child's health. So we have to assess further. And I'm stressing that because I know that's not something that we typically do, but we should pull those parents apart, talk to them individually and talk to them together as a unit. Find somewhere, maybe go for a walk on the hospital compound. I don't know, but find a way to find out what's going on. We have to assess further. The mother expresses frustration and concern about how to effectively manage the condition at home. You have to assess further as well. Why are you frustrated? What's happening at home? What are the concerns that you have? So it's not enough to just have these as subjective data. So this is the general subjective data from the scenario. When we have chosen a diagnosis, we won't need all of this subjective data for that diagnosis. So when we choose a diagnosis, for example, we've chosen to address the conflict between the mother and the father, then we will have focused more on collecting subjective data that's more detailed about that conflict so that we can find out what's really, really going on. General objective data from the scenario, the increased respiratory rate of 32 breaths per minute, the oxygen saturation of 90, and the physical findings, the use of the accessory muscles and the wheezing. But remember that on further assessment, we would have spoken about even the type of muscles that were noted to be used during the breathing, the intensity of the wheezing as well. Similar patient, the father stopped the medication due to concerns that the child being done when he takes it. See? Can't make these things up. Cannot. So let's say we chose ineffective airway clearance, and I noticed that a lot of persons didn't write it, and I think I know why. But does anybody want to tell me why didn't you write ineffective airway clearance? Nobody?
Miss, isn't ineffective.
Not hearing you.
Miss, are you hearing me now?
Yes.
Miss, isn't ineffective airway clearance has to do with mucus or airway obstruction, like for instance, mucus in the airway or mucus in the lungs that needs to be secreted in that case?
You said airway obstruction. What do you think is happening
Yes.
when somebody has asthma?
Miss, the narrowing of the
Right. So this is the airway, and it narrows. Isn't the airway now obstructed?
yes,
Miss, I always thought that it was only thing that blocking it. I did not know if, like, when it constrict, it also means it's obstructive.
Yeah, it is. So you can use ineffective airway clearance for bronchoconstriction, which is really what happens when somebody is experiencing an asthma attack. So the airway becomes narrowed. So the airway isn't clear. So we need to address that so that the patient has a patent airway. So we would diagnose them with ineffective airway clearance because they, on their own, are not effectively clearing their airway. No, typically, you do not use ineffective airway clearance when patients are able to cough and expectorate mucus and so forth. But this is not that scenario. This patient has asthma and the airway is constricted. So they still have the inability to clear their airway. So they're going to need help with clearing their airway. So we can diagnose them with ineffective airway clearance. Is that clear?
Yes, miss.
Miss, could you repeat that, please?
Ineffective airway clearance does not just have to do with mucus and clearing mucus. I see somebody said nothing there to clear. It's not about evacuating something from the airway. Read the definition of ineffective airway clearance in NANDA-I. It's not just about evacuating something that's obstructing the airway. The patient's airway is constricted due to bronchoconstriction. So they're not able to facilitate gas exchange because the airway is constricted. It's not clear. To increase airway patency, we would have to widen that airway to make it clear. We can still use ineffective airway clearance when there is bronchoconstriction. We don't have to use it for retention of mucus. The definition of the label allows us to use it for bronchoconstriction. You're welcome. So let's say we chose that diagnostic label. Ineffective airway clearance related to bronchoconstriction. We could say secondary to asthma exacerbation, as evidenced by shortness of breath, use of accessory muscles, increased respiratory rate, and we put the respiratory rate there, 32 breaths per minute, wheezing, and oxygen saturation of 90% on room air. A goal in this setting could be, and it's an asthma attack, right? When somebody has asthma exacerbation, we want that to be relieved quickly. You can't have asthma exacerbation and it's left unattended because the patient will become hypoxic. So we can put a short time frame within which this needs to be corrected because we need to clear this airway. So we could say within 30 minutes of collaborative care, the patient will achieve improved airway clearance as evidenced by decreased wheezing intensity from harsh to soft. So you see we're measuring how intense the wheezing was at baseline, helps us to find measures for our ways to measure the patient's improvement. So if we didn't note the intensity of the wheezing in our initial assessment, we wouldn't have been able to use this as a way to measure that the patient is improving. So we could say as evidenced by decreased wheezing intensity from harsh to soft, absence of use of accessory muscles to breathe, respiratory rate between 24 to 30. This is a 7-year-old. Their normal respiratory rate is 20 to 30. So this is where peds differ. So you have to know what the normal vital signs ranges are. And then we could say SpO2 between 95 to 100. And remember to always check that all the parts of your goal are there. So the ABCD, the audience, the behavior, the condition, and the degree, or the verb, the subject, the condition, and the criteria. That's something that we teach in the full care plan course. Clear so far?
Yes, ma'am.
Yes, ma'am.
Okay. But here's another diagnostic label that we would need to have for this patient, and it would be
Excuse me, miss.
parental. Go ahead. Hi, Wesley. A long time I don't see you either. You know? You're in year 4 now, right?
No, miss. 3. In
Yeah?
regards to the
Okay.
mucous membrane, the mucus, suppose it wasn't the constriction of the bronchial. Suppose it was a lot of mucus there. Would you still use the airway clearance, ineffective airway clearance?
If they can't clear the mucus, yes. If I have to suction the patient. But if the patient is able to cough and expectorate the mucus, I wouldn't use it.
What would you use? Ineffective breathing pattern?
If that's how the patient presents, yes.
Okay, thanks.
You're welcome. So this other diagnostic label is what we need to consider for the family. And again, this is where peds differ. Excessive parental role conflict. That label, if you read the definition of it on NANDA-I, you'll see that it fits perfectly for this family. So we are not just diagnosing the patient with the airway, ineffective airway clearance, we also have to diagnose the family. So excessive parental role conflict applies perfectly here because they do have conflict. And if you think about the related factor for this label, you might be tempted to say excessive parental role conflict related to disagreement about treatment approach. Raise your hand if you would have written that. They're arguing about how to manage the patient's asthma. So you would have probably written excessive parental role conflict related to disagreement about treatment approach. Let me see those hands. All right, Zoe, I see a hand. Anybody else would have written that? Brittany, I see a hand. Zoom user, change your name so I know who you are. So what would the rest of you have written? Type it in the chat. Situational crisis. It's so overused, Shamika. I think if I ask you, you wouldn't be able to tell me what situational crisis means. You would say probably a crisis in this particular situation. Yeah? All right, so I know you would have thought excessive parental control related to disagreement about treatment approach. And maybe even if you ask ChatGPT that, they would tell you too, but it would be wrong. It would be wrong. Remember, the reason we came up with the diagnostic label can't be the related factor for the problem. And this is where a little deeper thinking has to come. And this is where we actually help the patients when we do a little deeper thinking. So let's say we have the two parents here. They're having conflict. They're having conflict about how to treat. That's still not Tanya. They're having conflict about the treatment of asthma. Mommy wants to go the medical route. Daddy wants to follow his mother and go the alternative route. So they can't get along and they're having conflict. It's tempting to say excessive parental role conflict related to disagreement about treatment approach, but that's just a symptom. That's part of the evidence. It's not the cause of it. You have to do a deeper assessment to find out the cause, the reason why they're having this conflict. And when you do that deeper assessment, then you'll be better able to help these parents. For example, you might end up saying excessive parental role conflict related to ineffective communication. It could be that they're just not communicating effectively with each other. Mommy not understanding daddy's perspective, daddy isn't understanding mommy's perspective. And because of that, they end up having disagreement about the treatment approach. It could be as simple as that. It could be that they have different parenting styles, but you won't find that out unless you're doing an in-depth assessment. You could even say that it's because they've involved third parties in the decision-making process. And then it would be as evidenced by disagreement about treatment regime and so forth. But it's not related to disagreement about treatment regime. It is a disagreement about the treatment regime while we have diagnosed them with the excessive parental role conflict, but it's not the cause of it. Is that clear?
Miss, it seems like it's harder to get the related to.
Because you have to do more work, you have to assess further.
So means, give me a way how you would get more information.
So let's say, God forbid, I walking outside and I drop and I scrape my knee and you diagnose me with impaired skin integrity. Students typically write impaired skin integrity related to breaking continuity of the skin. But it is because there's a break in the continuity of the skin why you diagnose me with impaired skin integrity. The cause of my impaired skin integrity wasn't identified. You didn't find out why, what caused me to have the break in the continuity of my skin. Again, you typically write impaired skin integrity related to breaking the continuity of the skin, but it's wrong to say that because all you're doing is explaining to me why you've made that diagnosis. It would have been the same thing if you said excessive parental conflict related to disagreement about the treatment regime. You're not telling me what caused the problem. You're telling me why you came up with the diagnosis. The reason for the diagnosis is not the cause, it's not the related factor. So for example, it would be fall. What do you think my related factor would be? What caused my impaired skin integrity?
Sustained fall.
Fall.
Sustained.
Genetic diagnosis. If you use fall, like
you couldn't use fall, but fall alone wouldn't work. Shearing force could probably work. You would get away with soft tissue injury as well. So soft tissue injury from a fall, as evidenced by, and you describe my wound. But you have to tell the cause of the impaired skin integrity. Same like you have to tell the cause of the excessive parental role conflict, the cause of the disagreement. Why are they having this disagreement? If you don't address the real cause, then these parents are going to go home and they're still going to be having this conflict. Right? And then they end up back and the baby ends up back in the hospital with asthma exacerbation again because we as nurses didn't fully help them. Can you imagine how impactful nursing care would be if we really, really do it right? If we really had the time, because I know being short-staffed and so forth affects how well we're able to conduct patient care. Patient care or nursing care is deeper than just giving medications. Right? We have a larger mandate. Right? It would be our job now to say, sister, I'm borrowing your office to have a discussion with these two parents. You know, a big part of our job is sitting down and providing that type of service. Creating that environment where the parents can feel safe enough to express how stressed out they are, how they lack knowledge, and for you to be able to point them to specific resources and so forth. Nursing care is like that. That's what it should be. It's much more than just giving medications and going home. I wouldn't say secondary 2. I would say from fall. SC. Not sure who SC is. Go ahead, Tamisha. I see your hand up for a while now. And then Malaya. All right, not hearing from Bailey. Go ahead, Malaya.
Miss, I just want to clarify something. For the ineffective airway clearance, did you say it was related to exacerbation of asthma symptoms?
No, bronchoconstriction secondary to asthma exacerbation.
Oh, okay.
All right, so for the excessive parental role conflict, we could have a short-term goal like this. Within 60 minutes of independent nursing care, the parents will make an initial attempt at conflict resolution, as evidenced by parents engaging in a calm, non-confrontational discussion about asthma management with the nurse as mediator. And if you check for all the parts of the goal, you would see that they're there. If you're using A, B, C, D, or verb, subject, condition, and criteria, they're all there. So some interventions to achieve this goal. Remember, the goal is to get them to basically sit down and have a discussion in a calm, confrontational manner about asthma management. So to do this, you would establish a therapeutic relationship. So this is an intervention that students love to write, especially when we're dealing with psychosocial issues like this, like conflict resolution. If you're going to write that you're going to establish a therapeutic relationship with parents or patients, do not just leave it there. You must explain what you're going to be doing to establish this therapeutic relationship. One of the big problems that we have with nursing care plans from students is that they're so generic that they lack specificity, and they don't tell us that you know what you're writing about. You know, just think about you writing establish therapeutic relationship and your teacher coming to you after you submit the care plan and say, come here, how did you do this? Just think about how dumbfounded you would be, like you couldn't find words. Well, not many persons would have been able to explain how they did it because you weren't able to write who would have done it. So always be very, very specific in your interventions. What are you going to do to establish a therapeutic relationship? And usually you write it, but you write it in other interventions. You write about active listening, perfect environment, and things like that. But those are things you do to establish a therapeutic relationship. They're not additional interventions. So the first thing we're going to do is establish a therapeutic relationship with the parents by acknowledging and validating both of their concerns. Then we're going to discuss the benefits of conflict resolution, such as being able to agree on a course of action and specifically focusing on that plan of action so we can care for the child and optimize the child's outcome. So I would tell them that, hey, we need to come to an agreement so that we can make this beneficial for the child. Create a safe, neutral environment. How? We have to say we're going to be doing these things by choosing a private space with good seating. And I made a realistic suggestion that it could be the charge nurse's office. Set clear expectations for non-judgmental communication, such as listening when one parent speaks without interrupting and speaking calmly. Use communication techniques such as asking open-ended questions, active listening, paraphrasing to encourage discussion and exploration of underlying concerns. Assist the parents in searching for evidence-based sources of information on asthma treatment and management. Because remember what the problem is. One person wants the medical route, one person wants alternative route. So when they're in that safe space, you could facilitate them researching the benefits of the medicine and the benefits of alternative options. You know, so they have evidence to help them to determine which actions to take. And then you have the opportunity to show them how to search for and use reputable sources. So those are realistic things that you can do on the ward when you have a patient in this situation. And on top of that, you can provide educational resources on asthma management. Ask me again at the end of the class, Alejandra, because I had given several suggestions. Ask me again before we go. And to evaluate, always restate what the goal was. So the evaluation was something like, within 60 minutes of independent nursing care, the parents made an initial attempt at conflict resolution, as evidenced by parents engaging in a calm, non-confrontational discussion about asthma management. The mistake that students tend to make with evaluation is that they don't raise the goal. They don't rewrite the goal. Some diagnostic labels for PEDS. You might want to take some pictures of these slides if you struggle to find labels that are specific to this group of people. Ineffective chest feeding, there's also a risk diagnosis. And this is not a comprehensive list, but it's pretty good. Disrupted exclusive chest feeding, readiness for enhanced chest feeding, inadequate human milk production or risk for, ineffective infant feeding dynamics, ineffective adolescent feeding dynamics, neonatal hyperbilirubinemia or the risk for impaired child ventilatory weaning response, impaired parenting behaviors. They also have the risk for and the readiness for that label. Excessive parental role conflict, disrupted family interaction patterns, impaired family processes, risk for disrupted attachment behaviors, maladaptive family coping, neonatal pressure injury, and the risk for child pressure injury, and the risk for child falls, risk for accidental suffocation, risk for sudden infant death, decreased neonatal body temperature, also risk for delayed child growth, delayed child development, also risk for delayed infant motor development, also risk for, and ineffective infant swallow response. And of course, you have the general ones that could also be applicable, like ineffective airway clearance and so forth. Moving on to gerontology. Let's see if we can move a little bit faster. So just remember that gerontology is a study of aging and the challenges that elderly people face. And there's a focus on physical, psychological, and social aspects of aging. Common gerontological concerns. So if we're caring for patients in a gerontological setting, yes? Not hearing.
The last page that you were showing there.
This one?
Yes, miss. Well, I'm
I take picture, Karine.
yes, miss.
All right. So if you're caring for patients in gerontology setting, you know that chronic diseases are a main concern in those settings because the elderly are likely to develop chronic conditions like hypertension, diabetes, osteoarthritis, heart disease, COPD, stroke, and other cardiovascular conditions. Also, polypharmacy. No, the elderly usually have a lot of medications that they're taking, and it can be very, very confusing for them. And it's something that we don't really think about often, if we're being honest with ourselves. So that's something that we need to consider. Sometimes the focus is on the medical diagnosis that we forget to care for the person. And that's what nursing care isn't. Nursing care isn't medical diagnosis based, right? When we do it based off of medical diagnosis, we lose the whole patient picture. So we're focusing on caring for the diabetes that they're here for, but they have other conditions too that they're taking medications for as well. And yes, we might be focusing on the DM now because that's what they're admitted for, but then they go home and they start focusing on the DM too, and then neglect the other conditions. And then next week they're back with a complaint about the other condition because we weren't focusing on the whole patient when they were in front of us. So polypharmacy is a common concern in gerontology. That's something you should be considering when you're conducting assessments of your patients. Sensory impairments, effects of aging, pain assessment, incontinence, falls and mobility issues, functional impairments connected to mobility issues, nutritional deficiencies, cognitive decline, and changes in their mental health, social and emotional issues. Those are things that can arise in that setting. So we're conducting assessments, then you have to consider all of that for patients who are elderly. You have to talk to them also about preventative health and screening. You're going to be assessing how they feel about end of life care, depending on your age and the reasons why you're taking care of them. Sometimes they're so ill that we need to have them participate in advanced care planning. Sometimes they don't have family members. Sometimes they lack support. And just as there was for the pediatric, you also have ethical and legal concerns as it relates to gerontology. Access to community resources is also something that we have to consider when we have elderly patients. So with all of that in mind, when we are assessing patients who are elderly, then we have to remember all of those special considerations. So we need a comprehensive health history because we're prone to multiple diseases. So taking a comprehensive health history is going to be a longer process when we have elderly patients. We have to check their skin integrity. We have to check their ability to function. We have to check their mobility. We have to check their nutrition status. Be very careful as you do pain assessment for them because they tend to underreport pain. It's now on us to look for nonverbal cues that might indicate that they're in pain. Cognitive and mental health assessment. Are they losing their memory? Are they depressed because they're getting older? Do they have social support? Are they living at home alone? Do they live with other people? Do they have financial support? Do they have a pension? How are they taking care of their financial responsibilities? How do they identify as an aging adult? Because that can affect their mental status and overall care of themselves. We must consider doing a falls risk assessment when we have elderly patients and overall sensory assessment because those happen to change with aging. So let's consider this scenario. We have Mrs. Irene Walker, who is 82 years old. She lives alone in her apartment. She has 3 adult children who live in different states. Mrs. Walker was diagnosed with hypertension and and osteoarthritis 10 years ago. She's independent in most activities, but has begun experiencing some challenges with mobility and managing her medications. She visits the primary care clinic for regular follow-up care every 6 months, but her children are concerned about her well-being and her ability to manage daily tasks on her own. Recently, her family has noticed signs of forgetfulness and mild confusion. She's often unable to recall important events or medications, which concerns them. Mrs. Walker also seems withdrawn from social activities and has been isolating herself more than usual. She has not been going to her local senior center for a few weeks, which she previously enjoyed. Mrs. Walker is also complaining of pain in her knees, which has made walking more difficult. She also reports difficulty sleeping and sometimes feels down or sad, but hasn't been formally diagnosed with any mood. She has no history of falls, but mentioned that she sometimes feels dizzy when standing up too quickly. Which diagnoses come to mind? Giselle is asking risk for adult falls. No other diagnoses come to mind? Social isolation. All right, so it's easy to extract the subjective data from that scenario. We could say patient voice, I feel so tired all the time. It's hard to get up in the morning. My knees hurt a lot and I can't walk as much as I do. I don't go out much anymore. I can't seem to remember things like I used to and it's frustrating. I haven't been sleeping well and I feel down a lot of the time. I try to take my medication, but sometimes I forget. I live alone in an apartment building. I was diagnosed with DM and HTN 10 years ago. I sometimes feel dizzy when I stand up. And you can extract a lot of nursing diagnoses from this subjective data alone. Right. Activity intolerance is no longer Ananda Shanique. Decreased activity tolerance now. And then we also have subjective data from the family. So we could say family voiced, we're concerned about her ability to take care of herself at home. She is forgetting things frequently, medications, and sometimes she appears confused, like she does not know who we are or where she is. She no longer goes to church religiously, nor the senior center. So I kind of paraphrased a little bit based on the data in the scenario. So that's subjective data. We would not include all of the subjective data for each diagnostic label that we choose. We would extract the subjective data that's the label that we choose on our care plan. So bear that in mind. And then we can always assess further if we need data. Self-care deficit. Self-care deficit no longer no. What's going on here? This tells me that these students needed VHSI. Hey, Melissa, Bentley, where have you been? Eh? Imbalanced nutrition is no longer none, Tanika. Hey, wanna come upon the train. When you're assessing patients in general, you need to determine if you need additional data. So for example, just the data in the scenario a while ago isn't enough for us to write very good care plans for her. Whichever problem we identify when we're conducting an assessment, we should always ask for further information, do further assessment. If the patient is in pain, we need to find out for how long, where it is, what are the characteristics. And we use COSPA and PQRST for that. But you can use COSPA and PQRST for all other complaints as well. So she's feeling dizzy. When does it happen? What are you doing when that happens? How long does it last? Things like that. When you're feeling dizzy, do you have any other feeling? Are there any other associated factors? So always ask for more information when a patient makes a complaint. It's not enough for us to document patient feels dizzy. Right? We need to ask more questions. Is it after you've eaten, or do you find that it's only when you don't eat? You know, we need more data.
Excuse me, miss.
Go ahead. Remember to raise your hand so we don't interrupt each other. Go ahead.
I can't see the raise hand button, that's why, sorry.
All right.
In regards to more information from the patient, suppose that patient can't give enough information and the patient we don't see the patient relatives. How can we make a good diagnosis? Because sometimes what the patient tell you and when you see the patient visitor or relatives, they're telling you something else. So we can't based on what they're saying, you can't really make a good diagnosis off of it either. Because you don't know which one's saying the right one. Because I remember this patient, I'm asking her some questions, and based on what she's saying, it's different from what the relative's saying. So you don't know which one to work with.
All right. A part of our jobs as nurses when we're conducting assessments is to determine the reliability of the source. So we have to determine if we're able to get reliable data from our patients and the family members as well. Because it could be that the patient is the one providing the reliable data, not the family. Or it could be the family providing the reliable data, not the patient. We can do that over a series of days if we have the patient for days. We could do that throughout just by going back to the patient, sometimes asking back the same questions that we had asked earlier to see if we get the same response, checking for reliability. And that way we can help to determine if we can trust the data that we get from the patient. In the scenario where you have the patient on the ward, you have determined that the data is unreliable, but you don't have access to the family member, then you'd have to delay further assessment until you can speak to the family member. But what you could do is have the patient call a family member and talk to the family member on the phone in the presence of the patient. So remember, we can always reach family members, next of kins via telephone as well. Does that answer your question?
Yes, ma'am. Thank you.
Okay, you're welcome. So, general key areas to include in your objective data. And I listed these here because students tend to forget key things that need to be in objective data in general. So we must check the affected systems. One of the ones that I remember from this scenario would be the musculoskeletal system. It has the pain at the knee. I'm sure there are others. Vital signs, physical measurements where people like height and weight and so forth. Blood glucose, for example, in this case. Imaging, did the patient do any x-rays, ultrasounds, etc.? Include those. Blood tests, such as HbA1c, for example, or inflammatory markers. Since she has arthritis, I can't remember which one of the arthritis. Current medications, fall risk, if we did a falls risk assessment, mental health and cognitive function could also be assessed for the patient. General guidelines about what could be included in the objective data for this patient, but also for other patients that you might have. And using those guidelines, we could have objective data that looks like this for her. Vital signs, blood pressure 150/92 millimeters mercury, heart rate 84 beats per minute, respiratory rate 18 breaths per minute, temperature 36.8 degrees Celsius, oxygen saturation of 97%, weight of 72 kgs, height, BMI, recent blood work showing slightly elevated blood sugar, fasting blood glucose 112 milligrams per deciliter, limited range of motion in both knees due to osteoarthritis. Whenever we're mentioning a limitation in range of motion, we have to specify the limb and what the patient was able to do or was not able to do. Don't ever just write limited range of motion. Is it that they can't extend or flex or adduct? What can't they do or what could they do? Medications, she's on lisinopril 10 milligrams daily and acetaminophen 500 milligrams as needed. No recent falls or signs of physical injury from falls. So we did an assessment and we don't see any physical injury from falls. That's something we can note in the objective data for elderly patients since they are at risk for falls. Appearance, we could also note appearance as part of the mental health assessment for elderly patients. Difficulty recalling names of our grandchildren and recent events, that was indicated in the scenario. Diminished interest in social activities and avoiding family gatherings. Would those be objective data? Shamika, yes. The answer to that direct question is yes. Diminished interest in social activities and avoiding gatherings. Further, family gatherings wouldn't be something that the nurse knows, right? It would be something that the nurse is told. But the difficulty recalling names of our grandchildren and recent events, the nurse could have asked specific questions to determine that. So, right, this would be subjective. Nursing diagnoses from the scenario, risk for adult falls. I saw somebody mention that. Chronic pain from the osteoarthritis, impaired memory, as reported by her children and could have been assessed by the nurse. Acute confusion, or the acute confusion was reported by the family member. So if the nurse observed the confusion during her assessment, you could have diagnosed acute confusion. Inadequate social connectedness, ineffective sleep pattern, ineffective health self-management. Social isolation is no longer a NANDA-I. So the inadequate social connectedness is what you would use in place of that. Disrupted sleep pattern is no longer a NANDA-I. The ineffective sleep pattern is what you would use instead. I saw a comment that you're able to use the old NANDA, but activity intolerance has not been on NANDA-I for a long time. Even the old NANDA doesn't have it. All right. It was on like way back. It has been decreased activity tolerance for a very long time now. So yes, Tamisha, it would have been subject. So let us apply the nursing process to that patient. Let's say we've diagnosed her with risk for falls, risk for adult falls, and you would have written all of the risk factors. I wanted to share with you a different type of goal. It's very easy to write risk goals for risk diagnoses because you can just say the patient will remain free from. And in exams where you only have 4 hours to take care of a patient, I do recommend that you use that. Whenever you have a risk diagnosis, you say patient will remain free from. Easy to write, easy to achieve. But let's say that this was your patient and you're preparing her for being discharged. She has been on the ward for a long time. She's at risk for adult falls. She's going home later today, but you're caring for her today. You could have written within 1 hour of nursing, the patient will verbalize 4 falls prevention strategies to implement at home, as evidenced by patient stating that she will, 1, remove area rugs to eliminate tripping hazards, 2, install grab bars in the bathroom for support when using the toilets and the shower, 3, use a cane or walker when walking around the house to improve stability, and 4, ensure proper lighting in hallways and at night to prevent falls in low light areas or lowly lit areas. Now, if I came on the ward and you had written something like this and you said, Miss, my patient is going home today. She's at risk for falls. She has osteoarthritis. This is the goal that I'm writing as part of my discharge process for her. I would have been so impressed. So impressed because students typically write patient will remain free from falls. And by the way, you must say how you would know that the patient remains free from falls in your goal. What risk it is related to in the new NANDA bridge. I love this goal. Take a picture of it and use it. Interventions for that goal, you could discuss the home environment with the patient to identify potential fall hazards. So remember, we don't know the patient's home environment. Maybe having this discussion as part of the assessment would have been a good thing as well, so that you could have tailored the measures in the goal to be applicable to her setting. After that, we're going to educate on the importance of removing tripping hazards to prevent falls and injury from falls, such as the area rugs and electric cords. Instruct the patient on the proper use of canes and walkers, and we could collaborate with the physiotherapist to ensure they are correctly fitted and used. Let me see in the goal, did we say we're going to collaborate? Within 1 hour of nursing care. We could say nursing, independent nursing care, and collaborative care, since we've added collaboration in the interventions. We could show pictures of grab bars and suggest areas for installment, such as in the bathroom, near the shower, or the toilet. We could educate the patient on the importance of adequate lighting in hallways, stairs, bathroom, depending on the layout of the house that she gives to you. And she could use night lights when she's walking to the bathroom so that she doesn't fall. Instruct the patient to wear non-slip shoes or slippers with a firm sole to prevent slipping when walking around the house. Tell her that walking barefooted and with socks could increase the likelihood of falls. Advise patient to participate in physical therapy or exercises aimed at improving strength, flexibility, and balance at home. Advise the patient to involve family members or caregivers in the fall prevention efforts, such as helping with the home modifications, like installing the bars, offering assistance during tasks, and so forth. And for the evaluation, we would rephrase the goal in past tense and then put the measures and make sure that we're being specific. Within 1 hour of nursing care, the patient verbalize. Yes, Tamisha, definitely. The patient, you need to do a falls risk assessment for the patient, and we definitely need to get a score for them in the objective assessment. Yeah. Did we mention that? We mentioned the falls, but not a score for the fall here. But definitely, very good point. Within 1 hour of nursing care, the patient verbalized 4 falls prevention strategies to implement at home, as evidenced by the patient stating that she will do all of these things. Diagnostic labels that you can use for gerontology: chronic pain syndrome, ineffective thermoregulation, or risk for adult falls, impaired spiritual well-being, impaired religiosity, impaired immune response, adult pressure injury, or risk for impaired skin integrity, impaired social interaction. You could use this as well for replacing social isolation. Impaired surgical recovery, or risk for impaired cardiovascular function, decreased self-care ability syndrome, risk for imbalanced blood pressure. I love the decreased self-care ability syndrome. No, before this new NANDA came out in April, I always said that they should have had a syndrome diagnosis for self-care deficit, because oftentimes when we have a patient with self-care deficit, they have multiple deficits. They have deficits with toileting, bathing, clothing, feeding, and so forth. And then when we are writing care plans, it's difficult to just pick one and not write the others. But they've corrected that. They've added a syndrome diagnosis for patients who have all of those types of deficits in self-care. So it's called decreased self-care ability syndrome. So when you have a patient that has a self-care deficit in toileting, clothing, bathing, feeding, and so forth, then you can use the decreased self-care ability syndrome for them. Or you could say risk for, so there's also a risk diagnosis, which is wonderful. But if you're using the deficits, it's no longer self-care deficits. So that has changed. It's now decreased bathing abilities, decreased dressing abilities, decreased feeding abilities, decreased toileting abilities, decreased grooming abilities. It's no longer self-care deficits. Is that clear?
Yes, please.
Okay. Impaired intestinal elimination. So it's no longer constipation. Constipation It's no longer on under I. It's now impaired intestinal elimination or risk 4. Zoe, aren't you glad you came? Then chronic functional constipation or risk 4. Impaired fecal continence or risk 4. Impaired physical mobility. There's also a risk for that now, which I love. Impaired bed mobility, impaired walking ability, decreased activity tolerance, or risk for could be used. Inadequate nutritional intake to replace imbalanced nutrition less than body requirements. So this is the new label for it, and I love it. Risk for impaired water electrolyte imbalance, inadequate fluid volume, or risk for that used to be deficient fluid volume. It's no longer deficient fluid volume, is inadequate fluid volume. Disability associated urinary incontinence, risk for urinary retention, urinary incontinence, impaired urinary elimination, impaired gastrointestinal motility, or risk for excessive sedentary behaviors, imbalanced energy field, risk for ineffective blood glucose pattern self-management, effective fatigue self-management, no longer fatigue, it is ineffective fatigue self-management. And there's another one, I think it's excessive fatigue burden. Inadequate health literacy has replaced deficient knowledge. So it's no longer deficient knowledge, it's inadequate health literacy. I think there's inadequate health knowledge as well. I need to double check. And elderly frailty syndrome or risk 4. Ready to move on to mental health? This is the last category for tonight. All right, let's go. So I'm going to give you some common mental health concerns and just some general nursing considerations for them before we go into the third scenario. You have anxiety disorders, such as general anxiety disorder, which is where there is excessive worry or tension about everyday events. Usually, this is accompanied by physical symptoms like muscle tension, fatigue, or difficulty concentrating. I shared in a different class that sometimes when you're anxious and you have a certain pain, you need to identify if that pain comes whenever you're experiencing anxiety. When I was in nursing school, I used to have knee pain whenever I was anxious, like before exams or when I was very stressed. My knee, just one of them, would hurt very, very badly. Like nothing could, no pill or anything could help because it was associated with anxiety. Panic disorder is when somebody has recurrent unexpected panic attacks. So they experience like shortness of breath and palpitations and this sense of just losing control. Social anxiety disorder is intense fear of social interactions. Like they're very afraid, so they try to avoid social interactions and experience significant distress whenever they are forced to interact. For example, some persons might avoid going to group classes and speaking in group classes because they have social anxiety disorder. I have students in this class now who will not speak because they have undiagnosed social anxiety disorder. Post-traumatic stress disorder, PTSD, and I think they've changed PTSD to a different term. I can't remember what the term is. You can tell me, those of you who are doing mental health now. But that happens following exposure to a traumatic experience. Oh, I didn't do the nursing consideration. So if you have patients diagnosed with these anxiety disorders, a part of your assessment must be to check severity. So if you're going to write a diagnosis of excessive anxiety, in your assessment, we must see a rating of that anxiety because you must assess the severity of the anxiety, which is not something that students commonly So if you're going to diagnose excessive anxiety, which is now one of the labels, Ananda, it's not just anxiety anymore. Somewhere in the assessment, whether objective or subjective, depending on the tool you're using, there must be an assessment of the severity of the anxiety. Finding out what triggers the anxiety should be part of the assessment as well. And you should also assess the patient's ability to cope with that anxiety. Go ahead, Giselle.
I was asking, like, how do you like rate the anxiety? You said we had to rate it if we intended to use the nursing label.
So you'd have to use a standardized scale. So you can Google standardized scales and choose one to become familiar with so that you can always pull for it when you're writing your nursing care plans. But you'd have to find a standardized scale. Okay?
Okay.
Okay. Interventions for anxiety disorders would include cognitive behavioral therapy. And we talk about CBT all the time in care plans. Like I said, students write it all the time, especially for acute pain. But I've never actually seen a student do it. So make sure when you write CBT, you know what you're talking about and you know how to engage the patient in cognitive behavioral therapy. Relaxation techniques and checking if the patient has been compliant and adherent with their medications. So the SSRIs, the benzodiazepines, have they been taking them? Because if they have anxiety disorder that has been diagnosed, they would have been prescribed either strategies or medications. Mood disorders like depression or bipolar disorder. We use depression loosely, but it is really a persistent feeling of sadness and hopelessness that that's going to affect your ability to function. If you're able to function, the psychiatrist might not diagnose you with depression. So they also have this term about high functioning depressive, and I used to use it a lot when I was doing my master's. I'm a high functioning depressive person or depressed person. But really and truly, depression is diagnosed when you have persistent sadness and hopelessness to the point where it is affecting your ability to function, and you can't sleep. It affects your eating, whether too much or too little, but it's going to affect your ability to function. Bipolar disorder is characterized by extremes in mood swings. So it could range from manic episodes, elevated mood, hyperactivity, to depressive episodes, low energy, and feelings of hopelessness. If you have patients with mood disorders, assessment should include checking for suicidal ideation. You must check the patient's risk for self-harm. Collaborate with the other members of the team for medication management. Check that the patient is adherent and is compliant with the medications that have been prescribed for them. So that should be part of your assessment. Psychotic disorders like schizophrenia, which is characterized by hallucinations, delusions, disorganized thinking, and definitely an inability to function normally, like get up, go to work, and do social activities, like persons who are not diagnosed with schizophrenia or a mental health condition, then you know that those are symptoms. Other psychotic disorders like brief psychotic disorder, and you know you have a long list of different types of schizophrenia. If you have patients with those disorders, you need to monitor their symptoms of psychosis. What are the hallucinations about? When do they happen? Are they inciting self-harm? So that you can manage the patient's risk for self-harm or even violence against others. Check again for adherence to the antipsychotic medication. Are they taking them? Do they have support? Family education is a big part of managing psychotic disorders. So for this specific group and for the others, but definitely for psychotic disorders, the patient is going to need a lot of social support involving the family in the care and writing care plans for the family can also happen for these patients. Substance use and addictive disorders like alcohol use disorder and drug use disorders or behavioral addictions might also be conditions that you encounter. Alcohol use disorders. This is where there's excessive consumption of alcohol and it affects daily functioning. So a lot of persons don't consider themselves alcoholics because they're able to function. So they wouldn't be diagnosed with alcohol use disorder. But if it starts to affect their health, they can also be diagnosed with alcohol use disorder. Drug use disorders, addiction to substances like opioids, cocaine, marijuana, and symptoms of dependence could lead to a diagnosis of drug use disorder. Behavioral addictions like gambling, compulsive shopping, internet addiction, so much so that it starts to affect your ability to function, that would lead to a diagnosis of behavioral addiction. If you have patients with these diagnoses, then you need to assess the extent of all of these. How much alcohol are they consuming? What triggers the consumption of alcohol? Do they have a stressful job, stressful home environment? What? Are they exposed to rehabilitation programs? Have they been counseled? Are they taking medications to help with coping? Things like that are considerations. If you have patients with eating disorders like anorexia nervosa, bulimia nervosa, or binge eating disorder, then you have to tread lightly and carefully because it tends to be more challenging to create a therapeutic relationship with persons with eating disorders. Usually they deny that they have the problem until it becomes very, very obvious that they do. So a therapeutic relationship to find out why, what has caused them to develop this this belief or this way of life needs to be established. Definitely providing advice on nutrition, providing emotional support, helping to develop good self-esteem or a good idea of their body image is also part of the nurse's role. Personality disorders like borderline personality disorder, antisocial disorder, narcissistic disorder. Again, you have to develop rapport, but you also have to be careful about establishing boundaries with patients with these diagnoses. For neurocognitive disorders like dementia, delirium, Parkinson's disease, they recommend a calm, structured environment so that you don't agitate the patients who are confused and worsen their confusion. You want to decrease excessive stimuli, but you also want to promote conversation. So you have to be careful about how you do this. A big part of managing the neurocognitive disorders is helping the family to cope. It's not easy for caregivers to cope or care for patients with dementia and Parkinson's when they have a cognitive component, Alzheimer's and so forth. It's not easy. So a big part of nursing care will be helping the family to cope with the condition. So if you have a patient diagnosed with dementia, you'll probably end up writing nursing care plans for the family as well as for the patient. All right, let me run to the special considerations. So, of course, in mental health, building rapport and establishing trust is important, but you also have to know how to do a mental status examination. Mental status examination is going to involve you checking the patient's appearance, their behavior, speech, mood and affect, thought process and content, perception, cognition, insight, and judgment. Now, I have included a sample MSc before we go to it, and I'm going to ask somebody to read it for me, just so I get a break. But before we go to that, you also have to get a comprehensive psychiatric history from your patients in a mental health setting. Always check for risk of harm, both to self and others. Cultural sensitivity. How do people regard mental health? Some persons are very, very sensitive because of the phobia associated with mental illness. And there's also cultural differences in terms of how mental health is perceived and dealt with. So you have to pay attention to that when you're dealing with patients. Functional assessment, or are they able to function with the mental illness? Cognitive and neurocognitive assessments based on the specific condition, their symptoms and the severity of their symptoms. Assessing for compliance and adherence to the medication has to be a very, very important part of your assessment. Consent, the ability for the patient to give informed consent, is a legal issue. So sometimes the patient is so mentally incapacitated that they're unable to provide informed consent for their own care. You have to understand when it's time now to defer to the next of kin or the person who has the authority to provide consent on behalf of the patient. And that's going to come down to policy wherever you are. So that's something that you should definitely find out when you're working at a mental health facility. So this is a sample MSc. Anybody wants to read it? Or you can just take a picture and we'll move on. But if you want to read it, just volunteer, let me know. You can raise your hand. Jordan? Go ahead, Shanique. You can go ahead.
Sample MSc, date and setting. Conducted on October 10, 2023 in a private therapy office with John Doe, a 35-year-old male referred for an assessment. Appearance and behavior. Appearance. John presents as a well-groomed and neatly dressed man in his mid-30s. Behavior. He is cooperative, maintains eye contact, and exhibits normal psychomotor behavior. Affect and mood. Affect. John's affect is congruent with his reported mood, which appears to be mildly anxious. Mood. How would you describe your current mood? John responds, I've been feeling a bit on edge and worried lately. Thought process. John's thought process appears organized and logical. Thought blocking. John denies experiencing any thought blocking. Thought content. Delusions. John denies having any unusual or false beliefs, obsessions, and or compulsions. He reports occasional intrusive thoughts but can control them, suicidal or homicidal ideations. John denies any current or recent thoughts of harming himself or others. Perceptions. Hallucination. John denies any auditory or visual hallucinations. He reports no distortion in his perception of reality. Cognition, orientation. John correctly identifies today's date, location, and time. Memory. John accurately recalls the 3 previously mentioned objects: apple, book, pen. Attention and concentration. He successfully counts backwards from 100 by subtracting 7s. Abstract thinking. John explains the saying, don't cry over spilled milk, as not dwelling on past mistakes. Insights and judgment. He recognizes that his anxiety affects his daily life and states he would reach out to a therapist for support if feeling overwhelmed.
I don't know if I can come backward from 7s, but yeah.
Same.
Continue.
Speech, rate and rhythm. John's speech is of normal pace and rhythm. Volume and tone. He speaks in a clear and expressive tone. Language. There are no word finding difficulties or neologisms observed. perception of self and others, self-concept. John described himself as a responsible and hardworking individual. Interpersonal relationships. He reports positive relationships with family and friends, but mentions recent strain due to increased anxiety. Insight and judgment. Insight. John acknowledges his anxiety and its impact on his life. Judgment. He believes seeking therapy is a reasonable course of action when needed. Additional observation, psychomotor activity. John displays no signs of psychomotor agitation or retardation. Mannerism and gestures. There are no unusual or repetitive movements or gestures. Speech characteristics. John's speech is fluent with no abnormalities observed. Overall impression. John Doe presents as a well-groomed and cooperative individual who is experiencing mild anxiety. He demonstrates good insight into his condition and a willingness to seek help if needed.
Thank you so much. Of course, your MSc would accommodate your general examination of the patient as well. Let's go through this scenario. So we have Sarah Turner. She's 32 years old. She's a teacher. She's married with no children. She has a history of generalized anxiety disorder and depression. She was previously prescribed fluoxetine and lorazepam, but stopped taking her medications due to side effects such as drowsiness and weight gain. She recently experienced a stressful life event, the death of her father, which has triggered her symptoms. Presenting concerns, she presents with complaints of feeling overwhelmed, excessive worry about her future, sleep disturbances, insomnia, and lack of energy. She also reports feeling numb and detached from her usual activities. She has started avoiding social situations and is finding it difficult to focus on her work. She mentions feeling hopeless and has had thoughts of not wanting to wake up. Any diagnoses come to mind? Ineffective coping, no longer Ananda, they have maladaptive coping now. So yes, definitely maladaptive coping. Anything else? I'm not going to go through the subjective data I have here. Objective data would be elements of the MSc. Risk assessment in terms of our suicide risk. And diagnoses such as excessive anxiety is obvious, maladaptive coping. She's also at risk for suicidal self-injurious behavior, and ineffective sleep pattern are obvious. I'm sure there are others, but these would be like the top 4 that I could just obviously pull. So I've chosen to expand on risk for suicidal self-injurious behavior related to feelings of, somebody asked this earlier, risk diagnoses are now written with related factors, not as evidenced by. And when you're writing risk diagnoses, you have to be conscious that you're still writing a risk diagnosis and don't end up writing related to and then saying as evidenced by, because risk diagnoses are 2-part statements, not 3-part statements. So risk for suicidal self-injurious behavior related to feelings of hopelessness, detachment, emotional numbness, recent stressful event, the life event, the death of her father, pre-existing history of generalized anxiety disorder and major depressive disorder, passive suicidal ideation. She said she doesn't feel like she wants to wake up, social withdrawal, and the lack of social support system. So that's a diagnosis. For this diagnosis, I came up with 2 goals. We could have the easy one, which is the one where you have a risk and you just say that the risk won't happen. So you could say throughout the 4 hours of care, the patient will remain free from suicidal self-injurious behavior as evidenced by, you don't want any signs of suicidal self-injurious behavior. So as evidenced by absence of observable self-harming behaviors like scratching, cutting, or attempts to overdose. Or you could say within 1 week of collaborative care, the patient will develop and implement strategies from a safety plan when necessary. So she's going to develop a safety plan and she's going to implement the strategies from the safety plan. This is achievable in 2 hours, re-exam purposes. Which one? Which one you think might not be achievable, Nelson? Throughout the 4 hours of care, the patient will remain free from. So that's perfect for exam. Within 1 week, you wouldn't be able to use that in exam because we wrote 1 week, right? Because in exam, you typically have to write goals for the time period of exam. Keep looking over there because that's where the chat is. So you'd have to stick to the first one. You'd have to do, yeah, the 4 hours one is very, very achievable. Throughout the 4 hours of care, the patient will remain free from suicidal self-injurious behavior, as evidenced by, yeah, all you need to do is put measures in place to make this so. Say interventions will be aimed at preventing suicidal self-injurious behavior. So that's very achievable. But the within 1 week one, you wouldn't write that in exam setting. Unless you're at a school where they allow you to write long-term goals in exam like Knox does. So Knox does that. But for all the other schools that I know of, they tend to want you to stick to the time frame of the exam for your goals. Anybody here from Knox? So using this, can't remember which goal. I think I wrote the interventions for this one. Anika, you're here from Knox? Nice. So we're going to collaborate with the patient to create a personalized safety plan that includes specific steps to take if she experiences distressing thoughts, including identifying warning signs that her emotions are escalating, such as if she's feeling helpless or hopeless or numb. We would indicate to her that those would be warning signs. Assist the patient to identify at least 3 trusted individuals, could be friends, it could be family, it could be mental health professionals who she can contact when she's experiencing suicidal ideation or emotional distress. And we are going to ensure that she knows how to reach them. Educate the patient on coping strategies that she can use in times of crisis. For example, deep breathing exercises, grounding techniques. Grounding techniques would be like standing and pushing your feet down into the floor. Some persons like squeeze a finger. You can also use grounding techniques when you're anxious in exam, by the way. Just something to keep you back in the present. Because sometimes you're so anxious, your mind is all over the place. You can't focus on what's actually happening right now. You can use grounding techniques for that. Journaling or taking a walk could also be coping strategies in a crisis. We could educate the patient on cognitive behavioral therapy techniques that she can apply when distressing thoughts arise before she reaches crisis stage. So she could stop a distressing thought and reframe it from a negative thought to a positive thought. We could include in the safety plan phone numbers for emergency services like suicide prevention hotlines, local crisis intervention, and to make it so that you're not just writing an intervention to write an intervention, include an example so that you're demonstrating that you do have the knowledge and you will do what you say you're going to do on the care plan. So Jamaica Mental Health and Suicide Prevention Helpline is available. You might not know the number in exam, but at least you know that the helpline exists. And the evaluation would be within 1 week of collaborative care, the patient developed and implemented strategies from a safety plan when necessary, as evidenced by the patient producing a written safety plan and seen utilizing strategies such as deep breathing, calling a friend to talk with, and journaling when distressing thoughts arose. Some diagnostic labels that you can pull on for mental health: ineffective health self-management, ineffective health maintenance behaviors, inadequate health literacy, inadequate nutritional intake, acute confusion, chronic confusion, ineffective impulse control, very good one. Disrupted thought process is a very common one. Inadequate health knowledge. Yeah, this is the one that replaced knowledge deficit, deficient knowledge. It's now inadequate health knowledge. Impaired memory, impaired decision making, impaired emancipated decision making, impaired verbal communication, disrupted personal identity, very good one. Risk for impaired human dignity, chronic inadequate self-esteem, situational inadequate self-esteem, inadequate health self-efficacy, and disrupted body image. We do have a short mental health course. I think it's for $3,000. If you're doing mental health, that could help you. And that is it. You're good so far? I hope if you had like a personal objective for today, I hope it was met. Any questions?
Miss, can you go back on the previous page, please?
This one? Oh, you want to learn more about the mental health course?
The diagnosis, Miss.
No, no, say that you want. But yeah, the mental health course is asynchronous. You do it on your own time. It covers.
Thanks, Miss.
You're welcome. It covers a lot of the mental health diagnoses, and it comes with quizzes that will help with critical thinking. We do